Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
Today's episode is a rebroadcast of a lecture that I presented at the 2022 annual meeting of the American Academy of Ozonotherapy in Dallas, Texas. If you've not attended this meeting, you really should look into it, as you will hear fantastic speakers presenting really incredible stuff that you will never hear in a mainstream medically sanctioned meeting. This is really good stuff, and it's so useful in your clinical practice. I encourage you to look at their website, aaot.us, to see what they have to offer, and plan on attending one of their meetings in the future if you really want to improve your clinical outcomes. Dr. Frank Schallenberger, who founded the organization, was a guest on the Pod of Inquiry back in Season 1, Episode 8, and is an icon to say the least. He has so much insight and expertise that I highly recommend going back and listening to that episode after you listen to this one. Please enjoy this lecture that was presented last year at their great meeting. I really appreciate that introduction, and prior to the conference, my goal was to try to share with you some really cool things about peripheral neuropathy and maybe how to distill it and understand it a little bit better and how to go about treating it. But that goal has been subordinated with just the ability that I want to have to press the right button. So, and we'll still cover the second goal as well. So the question or the title is, does ozone therapy have any therapeutic future for neuropathic conditions? And the answer is yes, it definitely does. And I will preface everything today that I am not an ozone expert. I'm an ozone neophyte. I started basically being introduced to ozone therapy in about 2018, 2019, and we're still in a very significant learning curve, and that's why it's so good to be at a conference like this. Now, peripheral neuropathy is a really horrible term because what does it mean? If I asked everyone in the room, do you have a vehicle? Most people are going to say, oh yeah, I've got a vehicle. And I've got a vehicle too. It's a John Deere tractor, and I like that vehicle more than my other vehicles, but it doesn't really tell us anything. So the nomenclature itself is very poor. So basically, peripheral neuropathy just means that it's something peripheral or outside the central nervous system, and there's some type of problem or pathology with the nerve, not very specific. So when somebody is given a diagnosis of peripheral neuropathy, that's really a symptom. It's not a diagnosis. So you have to try to figure out what's going on that's causing that symptom that we categorize as peripheral neuropathy. If you look at the literature, there are so many different types of peripheral neuropathy. There's so many different names. There's hundreds of different types of peripheral neuropathy. And it's very difficult to try to get some type of semblance and understanding in peripheral neuropathy when you start treating it, because when you're reading all of these things, sometimes they're the same thing, but they have two different names. So it's something that I think can cause another type of neuropathy, and that's called exploding head syndrome. And I think I have a little bit of that after all the great lectures this week because of all the information. But I wanted to take some time to try to figure out how to break this down so that you can understand it and basically simplify it so that you can start looking at this from a more simplified manner in your patients. So it's really hard to keep track of the names of all of these things, and sometimes when you have EHS, or exploding head syndrome, you lose sight of what's really going on. So we're going to try to help break that down a little bit so that you don't get lost in the weeds, so to speak. So everybody can see this nice and tidy algorithm on the left side of the slide, and algorithms don't work real well. And the first thing you probably should do is forget that algorithm and just, put all these algorithms in the garbage, because one of the things that I've learned from really being focused on peripheral neuropathy is that there's no two cases that are really exactly alike. There's a high degree of variability from patient to patient, even though we give them a nice tidy name for their peripheral neuropathy. So this is my colleague, Dr. Andy Rader. He's really one of the world's experts in Charcot neuroarthropathy reconstruction. And we discuss a lot of things. And I just thought this slide was very appropriate because his glass of wine is empty. And that's how we feel sometimes with these patients. What else can we do? Because we've kind of struck out with all of these other things. It's a very complex thing. Now here's a very subliminal thing that you might pick up. So maybe we can fill that glass with ozone. You see, that was very subliminal. So now let's look at complexity for a second, right? Everybody's heard of tarsal tunnel syndrome, right? I mean, it's pretty common. There's still, believe it or not, some folks who will not recognize that it actually even exists. I don't know how that's the case. They're probably the same folks that are looking for the edge of the flat earth. But when you look at something like tarsal tunnel syndrome, you think, wow, this is it's pretty straightforward. Well, my son's a mathematician and an engineer, and I asked him one day, I said, listen, if I gave you all of the different factors that we look at from a standpoint of what's causing this person's tarsal tunnel syndrome, could you calculate that out? And he said, yeah, just list everything out, all the different things that you have to take into consideration. And he came back about 5 minutes later and he said 178,272 different permutations of what could be contributing to this person's tarsal tunnel syndrome. So that's something that is just very well known, but yet not appreciated for the complexity. Peripheral neuropathies most often start in the lower extremity. Well, why is that? And the answer is probably because of the biomechanical demands that are going on with the lower extremity versus the upper extremity. But we'll get into that a little bit more. But if you think about how much is happening from a biomechanical standpoint in the lower extremity, it's pretty incredible. Somebody takes 10,000 steps in a day, 2 to 4 times body weight's going through that extremity, step after step. You can see how easily it would be. And then if you add on to that, maybe some vascular or venous insufficiency, and now they have edema, it's pretty easy to see how these nerves in the lower extremity would be affected previous to the nerves in the upper extremity. So one of the ways we can break down neuropathy is this table here. And I'm not sure these numbers are exactly right because you can go to many sources and you'll see different numbers, but this is relatively close. And if you look at the two big ones, idiopathic, which means we're idiots and we don't know what's going on, and diabetic peripheral neuropathy, you're covering a good majority of all of the cases that we see from a peripheral neuropathy standpoint. And probably the idiopathic component, if you really think about it and really work up your patient and look at them globally, that number from 23% can come down significantly with just extra, judicious examination and spending time listening to the patient. So, now, of these, I want to emphasize that there are 2 types of neuropathies. Essentially, this covers everything. One is a compressive neuropathy, and the other is a non-compressive neuropathy. So, if we know that something is compressive, then we're able to actually surgically treat that component. I'm going to give you an example in just a minute or two. Now, chemo-induced peripheral neuropathy is not always a compressive neuropathy, but many times it is. And if we can figure out if it is compressive, and I'll explain that more, then we have a definitive treatment that we can go in and do something that really benefits that patient greatly very quickly. So, I already said this, but why is it important to figure out if there's a compressive nature to the neuropathy? And the answer is because if you have a significant compression, you can help that patient greatly. But if they have a compressive neuropathy and you don't address it, the likelihood of all of the other things that you do to make that patient better are not going to really get them rid of their symptoms that they're having. So you need to be able to identify if it's compressive. So this is a great slide that illustrates the difference between a systemic or metabolic effect on the nerve and then this feedback or loop back from compressive neuropathy or focal compressions or entrapments back to leading into more systemic effects or metabolic effects. So I'll get into that in a little bit. But I want you to think about that there's this feedback between diabetic or any type of systemic nature that is like diabetic peripheral neuropathy, but you have to think about, well, what is that systemic condition or metabolic condition actually doing to create this compressive nature of the neuropathy. Hopefully that'll be less confusing. Now, there's a couple of things, that you don't think about as being a compressive neuropathy, and leprosy is one of them. But mainstream medicine really doesn't recognize that. There's a group of very expert peripheral nerve surgeons in our Association for Extremity Nerve Surgeons that have been going down to Peru for over 20 years now, and they're doing isolated peripheral nerve decompressions in these patients, and they reverse their symptoms, and they never have any loss of fingers or toes because of insensitivity. So that's kind of an interesting compressive neuropathy, and people don't necessarily think about compression. And then the most common, and we've had a lot of genomics and that topic of discussion so far, and probably true genetic aberration is a very small subset of peripheral neuropathies, but the most common is Charcot-Marie-Tooth disease. And one would have to ask, well, is this a compressive neuropathy? And it has a compressive nature to it, and you have to ask yourself, well, why does it preferentially select one of the two terminal branches in the lower extremity, the common fibular or common peroneal nerve, versus affecting the tibial nerve? And this can be treated with nerve decompression. So we're going to talk about nerve decompression a little bit, how it can basically reverse these types of conditions. Now, this was a pretty recent article, and COVID's an interesting thing because there are a lot of things that are happening, and if you look at these, the data in this, that they had these people who developed peripheral nerve injuries after they had COVID-19, and they were all in very sick patients, and my suspicion, or what I would suggest is probably going on here, is that these are not necessarily induced by the spike protein. They could be, we don't know that, but they could be just from the standpoint that when that patient's laying in bed, their legs pressed up against the side of the railing of the bed, or they're positioned wrong and their brachial plexus is in a bad position. So these are really more of a subsequent entrapment to somebody who has had COVID. So it's kind of interesting. Now, everybody's familiar with carpal tunnel syndrome, right? It's the most common nerve compression or nerve entrapment in the human body. In the general U.S. population, it affects about 2% of the people. But if you look at the diabetic population, depending on what article you look at, it's anywhere between 14 and 28%. Now, this is a really astounding thing because there's something going on with the diabetic patient who develops carpal tunnel and the patient, the disease, what's going on to cause all of this carpal tunnel. And this is really an important thing, because if the patient has had a successful carpal tunnel decompression and they're diabetic, they almost have a 100% chance of success with a lower extremity peripheral nerve decompression. Now that's really interesting. It was a study done out of the University of Arizona, their neurosurgery department, and it's a pretty robust and good study. But I love that, because when I ask a patient when they come to our office, did you ever have carpal tunnel? Oh yeah. And did it get better after they decompressed it? Oh yeah, it's great, it's still good today. Well, that's a really great indicator that this patient will get better with other peripheral nerve decompressions in the lower extremity. So my journey into neuropathy was really unplanned, and we talk frequently about how we want to try to plan for life. I think that we can do that to some extent, but then life ends up planning us. And I know everyone in this audience has experienced the like, how did I get to where I am today? Because I might not necessarily plan that, or I had the ideation that that was what was going to be. So when I was in a regular podiatric practice, we did everything. And most of the time when a patient came in with neuropathic symptoms, we would say, well, sorry, there's nothing that we can do for you. We'll give you a little gabapentin or pregabalin and be off, because it's a condition you're going to have to live with, and that's it. Rest of your life, you're going to have peripheral neuropathy. And then in early 2001 to be exact, I happened to cross paths with my mentor, who is in the green circle here, Lee Dellen, and he's a professor, actually he's a retired professor of plastic and neurosurgery at Johns Hopkins University. He just retired last year. You talk about a human that has a big ripple effect. This gentleman has a gigantic ripple effect. He's trained so many peripheral nerve surgeons, written textbooks, and I still don't know why he liked the little fat kid in the back, but he and I kind of clicked, and he took me under his wing. Now, this story really started in about 1982, 1983, where Lee was working in the hand clinic at Hopkins, and it was conventionally taught, and it's still being taught today, that once you have peripheral neuropathy and you're diabetic, that's it. You can't restore your sensation, and you're just going to have these symptoms. Well, neurologists don't have a conceptual problem with sending a patient with a carpal tunnel and diabetic peripheral neuropathy over to have the hand surgeon decompress the median nerve and treat their carpal tunnel. But what happened was that he had these patients that had tremendous carpal tunnel pain, that were diabetic and had diabetic peripheral neuropathy in their feet and legs, and he would decompress that carpal tunnel, and they would come back and they would say, wow, this is great. My pain is gone, but I have sensation in this finger, and half of this finger. Now, that wasn't supposed to be, right? Because that's not what's being taught in medical schools. And so then he thought, well, what can I do for the little finger? And then went up to the ulnar nerve at the cubital tunnel, decompressed that. Guess what? They got sensation back in their little finger. Now, this was an insensate hand, and he restored it. But then they said, well, can you do anything for the back of my thumb? And so he went and looked at one of the branches of the radial sensory nerve, decompressed it. Lo and behold, this patient who had numbness in their hand no longer had any numbness in their hand. So this really made him start to look at this. And the next question was, what can you do for my feet? And he's like, I have no idea. I'm a hand surgeon and plastic surgeon. I don't really go down there that much. But because he was at Hopkins and because he was an incredible researcher, he got into the cadaver labs and figured out that there are 4 sites primarily that these tight tunnels, like the carpal tunnel in the hand, exist in the lower extremity. We'll talk about those in just a little bit. But he then started decompressing the nerves in the lower extremity of these patients that he had done their hand surgery. And interestingly enough, about 75% of them had restored protective sensation, which is a very big deal because you know how severe diabetic foot ulceration is, and the propensity to go from a diabetic foot ulcer to a subsequent infection and then a subsequent amputation. And once you lose a leg to amputation, your 5-year mortality is really not very good, okay? It's up there with a lot of very bad cancers. Well, because he was at Hopkins, they said, you don't have anything other than this clinical data. You need to prove in some type of an animal model what you're doing and why there's any effect. Well, in 1978, there was a couple of publications, a couple of articles by a gentleman that published in Diabetologia, and his name was Jacobson, spelled funny, like a different variation of how you would think it was spelled, but you can find it. And what he did, what Jacobson did, was he went and he made his rats diabetic. So he injected them with streptozotocin. They got very high blood sugars. They were very sick. And then at 6 months, which is a significant portion of their life being a rat, he would sacrifice them and then do photomicrographs of their sciatic nerve. And what he found was the cross-section of the nerve showed that there was really very little demyelination. Now, everybody is taught that demyelination is the cause of the symptoms in diabetic peripheral neuropathy because of the systemic effect and all of that. But Jacobson didn't find that. In fact, he found relatively good neurons that were myelinated, but they had a real high water content. So Jacobson was able to demonstrate that the diabetic nerve swells and it gets bigger. And I'm going to try to play this. So this is what happens. So glucose overloads the nerve and it messes up the hexokinase pathway, converts into another sugar called sorbitol, and for some reason sorbitol loves water. It's very hydrophilic. Even though it has almost the same molecular weight as glucose, it draws the water into these nerves. And that's what Jacobson found in his early studies. So Lee then took Jacobson's work and he basically did tarsal tunnel decompressions on rats. Now think about that. Rats have pretty small tarsal tunnels. But he would then take half of his rats and do tarsal tunnel decompressions in them. And the other half, he left their tarsal tunnel intact. And then he made them all diabetic with streptozotocin like Jacobson did. And each week, he would run them across paper with their paw prints, their paws dipped in ink so that he could measure the degradation of their paw print. So if you're neuropathic, what happens? You lose, motor strength, and so the paw of the rat will change. But the paw didn't change in the people in the rats and some of our patients are rats, so maybe that. But anyhow, the point is that he could prevent the symptoms, at least in the rat paw, from a degradation standpoint by doing a prophylactic tarsal tunnel surgery. So that's really pretty interesting. So Hopkins said, well, that's all nice and well, but you need to do something in primates, okay? So he did do that in primates. I'm going to show you one of his primate patients in just a little bit. And then he went back and did a second, basically the same study that he did off of Jacobson's work, did that again, and then that has been replicated from the Cleveland Clinic. Maria Semenau, I don't know if you ever heard about the first face transplant. So Maria was the lady who did the first complete face transplant, and she's an excellent microsurgeon. But anyhow, they confirmed Lee's work some 20 years later. So this has been known for quite a period of time, but yet it's still not recognized, and it's hard to believe, but when people are in their paradigm, it's hard to sometimes get them out. So in the lower extremity, we have 4 primary tunnels, as we can see here, that are potential areas for constriction or entrapment if the nerve swells. The common fibular or common peroneal nerve at the side of the knee, the superficial peroneal nerve on the anterior distal 1/3 of the lateral aspect of the leg, the tibial nerve at the tarsal tunnel and its branches, medial lateral plantar nerve, as well as the medial calcaneal nerve, and then the deep peroneal nerve on the top of the foot. So if you think about that, if I create a nerve compression in these 4 tunnels, then you're going to see that you could essentially create a complete stocking distribution of the neuropathy. And everybody talks about stocking and glove distributions. You've heard about that, right? Well, the sural nerve doesn't have a known tunnel for entrapment. And so a lot of times when you test these patients, they'll be totally insensate within the distributions of these 4 nerves, but their sural nerve is completely unaffected, which would tell you that it has to be some type of a compressive effect, and the sural not having a known tunnel or a known site of entrapment kind of speaks volumes to that. And in fact, the gentleman that I showed you with his wine glass empty, but we filled it with ozone, Dr. Rader, he has a video of him doing a transmetatarsal amputation in a diabetic patient that was completely insensate, and so he didn't use any local anesthesia or general anesthesia. And as he's cutting across from medial to lateral, and this is a guy that had metatarsal 1, 2, 3, and 4 transected with no anesthesia, and when he got to the 5th one, he said, hey, I can feel that, need to numb this up. So why would that nerve be spared versus the others? And the answer is, well, it's swelled, but it just doesn't have a known tunnel to capture that swelling and create a focal nerve compression. So it's very interesting. Now, this is the primate from what I referred to earlier, and if you look at the photomicrographs on the left side of the screen, you can see this is tissue taken from a 31-year-old primate that was a type 1 diabetic primate, and they named her Sweetie, and she was at Hopkins all of this time. They used her for a lot of their basically their studies, because primates evidently don't have a high level of diabetes, especially type 1, and it's really sad that we call things diabetic type 1 and type 2, because they're really distinct, completely different diseases. But regardless, these were sections that were taken from the ulnar nerve, the sections on the left of the ulnar nerve up in this part of the arm where there is no known site of entrapment. The same nerve, as you can see in the right side, is the cubital tunnel. Okay, and you can see the myelin's vastly different from the left to the right. Now, if it's solely a systemic disease, how can that be, right? Because the glucose, I'm pretty sure the glucose level at this part of the arm is the same as 2 inches south at the cubital tunnel. So this was really very confirming evidence that it's not just this metabolic destruction like you've been taught, but it's making the nerve swell, and then that's what's causing most of the symptoms of diabetic peripheral neuropathy. Now, this is an intraoperative photo of one of our patients, common peroneal nerve. You can see on the left part of your screen, I'm a little scared to try using the pointer because I could mess up, but I'm going to give it a whirl.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. Several years ago, I chose Alpinion as my ultrasound brand of choice after years of experience and research into ultrasound imaging. In fact, I have 2 of their machines. Alpinion has incredible precision and penetration built into their technology that, in my opinion, is simply the best value in all of the ultrasound imaging space. They have several price points to meet your needs, and I can tell you definitively that you'll end up having to pay double to achieve the equivalent imaging quality from other top brands. That doesn't even account for the unlimited software updates and remote tech support included with no monthly fees. Right now, to show their appreciation for the listeners of the Pod of Inquiry, they're offering an incredible discount. Their portable i7 retails for $21,000, but you can get it discounted at most medical meetings for $19,000. But my listeners will get it discounted to $15,900. This has never been offered anywhere for the new portable system with the engine of a console system. Use code SBPOI to take advantage of this incredible offer. You won't be disappointed with Alpinion. I sure haven't been.
Oh yeah, oh look at this. Okay, so that's a success right there. I don't need to do anything else. Thank you, let's go to the cocktail hour, okay? So you can see these bands of tissue across this nerve, and this is the border underneath the peroneus longus muscle, and the anatomists are trying to trick us up too. It's just like when I get comfortable with my password on the EMR, then they change it automatically and it just totally messes me up. So the anatomists decided that they would call it, instead of the common peroneal nerve, they'd call it the common fibular nerve, and they would call it the fibularis longus instead of the peroneus longus. And for an old dog like me, it's really hard to, handle that kind of nomenclature change. But anyhow, you can see this nerve really is constricted, and here, after we've decompressed it, you see this little vein, or vasa nivorum, that appeared. Now, what's really interesting is that we brought a neurologist in for 11 cases to do intraoperative nerve monitoring, and there's no placebo effect with intraoperative nerve monitoring. The patient's asleep, and what they found was as soon as we started decompressing this, that nerve started to function. Now, wait a second, people will say, the nerve can't regenerate in a minute and 30 seconds. And the answer is, yeah, the nerve can't regenerate in a minute and 30 seconds because we know that nerves regenerate at about a millimeter a day or an inch a month, and it takes time for nerve regeneration. So there's a couple of processes that are happening here, and one is ischemia. Now, I don't have any slides of this, but I think it's a very compelling thing. If you have, a couple of minutes to waste, you can, and it's not a waste, it might be actually very beneficial for some of your folks that maybe have a drop foot that's unexplained or that type of thing. But if we're able to, with ultrasound guidance, I can put about 0.2 cc of lidocaine on this nerve, and within about 4 minutes, if this is an entrapped nerve, they will have increased motor function. And you scratch your head going, well, why is that? And when I first saw this in 2017, it was hard for me to put my head around it, but all local anesthetics except one. Does anybody know which one is not a vasodilator? Cocaine. That's why ENT still uses it, because it causes vasoconstriction, but everything else is a vasodilator. Marcaine is a more potent vasodilator than lidocaine. So by putting 0.2 cc to 0.4, 0.5 sometimes is the most, next to the nerve where there's a focal compression, in about 4 minutes they will regain motor strength in their anterior and lateral compartment. So in a patient that has a drop foot, a lot of times they're told there's nothing that can be done for it, and the answer is, well, if you put a little bit of lidocaine in on that nerve and you get a positive, we call it a positive Phoenix sign. So if you go to YouTube and put in the Phoenix sign nerve block, you'll see a 3-minute video showing how we administer this block. But it's very, very diagnostic, not only from it's sometimes very hard for clinicians, very astute clinicians, to figure out what's coming from the back versus what's coming from a local focal nerve compression, and this pretty much answers it. So then we had to, I don't want to say prove, but we had to try to strongly support that this was a vasodilatory phenomena and not some weird sub-anesthetic phenomena. And we did a double-blinded, randomized prospective study comparing lidocaine to papaverin, which papaverin's been around for a long, long time, very well understood vasodilator. And the same response happened with the people that we injected with papaverine. And that study has been submitted for publication, and hopefully it'll be out in the very near future. So anyhow, this shows you kind of what happens from a neuroischemic event when you have a focal compression, and when you see this kind of a, there we go. I might dislocate my shoulder trying to get this arrow over there. You see this little dent right here and the little dent right there? That's where this band of fascia was riding over that nerve, and this is what we call an hourglass deformity. So there you go. So that's kind of an interesting thing. Now, when I came across Dr. Dellon's work and met him and I actually ended up helping him teach these courses, and I was blown away. All right, I had a new hammer, and I was going to pound every one of these diabetic nails because I had the hammer. That's the surgeon mentality. And we did really well. Quite frankly, we did, we had a 90% reduction in pain. So that 90% of the time, we didn't maybe eliminate all of their pain, but 90% of the cases, we had a dramatic and improved reduction in their pain. 75% restoration of sensation. This is a very big deal because if they feel, they can heal, and they won't develop a diabetic ulcer if they have protective sensation. They had improvements in balance, and what kills more people over age 65 after you take out cardiovascular and cancer, and it's probably falls, right? And it's a big problem, but we're able to improve a patient's balance if we can restore proprioception and increase their motor function. So it's pretty powerful. But like I said, as a surgeon, you give me something and everything is going to be a nail, and it just doesn't work. Sometimes it's not a nail, sometimes it's something else. And we had a lot of patients that would come back and they would say, I'm so much better, but I still have this burning, or I still have, some other type of weird neuropathic symptom. And so by default, I was forced to go from a surgeon mentality into, well, I actually have to look at this patient from a global perspective, what's going on with them metabolically, what's happening that's causing these other symptoms that I can't get better from nerve decompression. So I loved my fortune teller. I've been trying to get this on Amazon for quite a period of time, and it's on back order, unfortunately. Now here's another little subliminal thing. What do we do for these patients? And he's looking in the ball, and there it is. Maybe some ozone, right? Maybe we can make them healthier. But peripheral neuropathy is really a very difficult thing to treat. Anybody that says it's easy and you just give them some gabapentin or Lyrica or Cymbalta, it's like you need to run away from them because they're not understanding it. So we need everything we possibly can in this chess game, so to speak, to try and just deliver this patient a little bit more optimal care. So we've kind of now broken down neuropathies into a compressive nature and a non-compressive nature. And we're going to treat them to some extent the same way, but with it being a compressive neuropathy, we have a better, obviously from what I just told you, we have a much better success rate with that. So what is it, what's going on in this patient that is kind of universal or common to all of these different types of peripheral neuropathy? And the answer is, well, neuroinflammation is probably the number one thing. Less than ideal host. Now, do you all see less than ideal hosts in your practice? I mean, I have not even seen one ideal host yet that's come in and has, a non-traumatic peripheral neuropathy. They have microvascular impairment. They may have some demyelination, oftentimes a focal neural ischemia like we talked about. So those are common themes to what we're seeing, and it's really irrelevant what name we've given it because we're going to want to try to treat those different aspects and try to make that better. So one of the ways that people have studied nerve compression, what happens is, what's happening at a histological level, and that they use what's called Bennett's model of nerve compression. And basically what they do with this model of nerve compression is they really put a very small constriction. And they're not putting a ligature around the rat sciatic nerve and tying it down. It's just a very light constriction, and then they look at what happens. And they are able to see a lot of interesting changes. Now, these two slides that you see in the picture, this is a suture-induced peripheral neuropathy where this surgeon had done a bunionectomy and for some reason used this ungodly huge piece of rope to close the capsule of the first metatarsal phalangeal joint, and they basically lassoed the dorsal medial proper digital branch to the hallux. And it was interesting because the patient would only have pain if they had her pull her toe up. So the nerve was running through this ligature, and when she would dorsiflex, it would just pinch right down on it. And you can see the piece of suture there. So what do we know from Bennett's model? Well, remember that drawing that I had compressive over here and metabolic over here, and the arrows going back and forth in this circle. And this shows why the compression of focal nerve compression can create a systemic effect. And so what they've seen in Bennett's model is T cell inflammation, which amplifies the neuroinflammation, and TNF alpha is upregulated, again, another contributor to peripheral nerve injury, neuropathic pain. And then what they also found with Bennett's model of nerve compression was that decompression surgery decreased the development of the upload or upregulation of TNF alpha and decreased the T cell recruitment. So there is not just a benefit from improving the microvasculature by removing these sites of compression, but there is also a histological benefit. So during his journey at Hopkins, and what they were trying to do was establish how long it took for a nerve to demyelinate, and McKinnon and Dellon published this, like you can see, 1985, so this stuff's been around for a long period of time. But you can see in the upper left photomicrograph, again, myelin's pretty good, then at 6 months it's dropping out, 12 months it's negligible how much myelin is really there, and then after they would decompress it, it would remyelinate. So you had remyelination, which was very important because that was one of the criticisms about what Lee was doing with nerve decompression in diabetic neuropathy. It's like, well, these people are diabetic, they're not going to heal. And the answer is diabetic nerves do heal, they do regenerate, albeit slower. They have less axoplasmic flow than an ideal non-diabetic nerve, but they do heal and they do remyelinate. So it's kind of interesting. So we go back to these factors of what we see in almost every neuropathy, and we look at, well, what can affect all of those? What can positively change these? Well, ozone. And, we can maybe deal better with this neuroinflammation. We can make the ideal host, or maybe we can make the less than ideal host closer to being an ideal host, and that's going to help them in many other ways from a health standpoint, not just from their peripheral neuropathy. And then it can help with demyelination, and so what's going on here? So, like I said, I'm not an expert in ozone, but I've been around it enough that I want to become more informed by it. I don't think after seeing what you all have done this week that I could ever become an expert in ozone, but I certainly would like to try to get closer to it. And if we look at, well, what is ozone potentially doing? Well, it's immune modulatory, right? It has very significant and potent analgesic effects. Not all neuropathies are painful, but some are really painful, and these people, in many cases, are suicidal. It's so bad. Anti-inflammatory, obviously, all of these neuropathies have this component of neuroinflammation. It's antioxidative, and it upregulates nitric oxide. So that's a big thing, right? Because all of them are nitric oxide deficient, and anytime we can increase their nitric oxide via ozone infiltration or insufflation or even MAH, that's going to help in addition to supplementing them. So there's some articles that we pulled out. So what happens with peripheral nerve injury? And I don't know if this peripheral nerve injury in this particular study was Bennett's model. It could have been something much more dramatic. But basically you get a lot of increases in activation in the cortical frontal areas, genetic changes. I was talking to Dr. Kapoor earlier today. I was really fascinated by his talk. And I thought, well, you know, maybe we need to start looking at some of these people a little bit more closely from a SNP standpoint and see if there's some common theme. And so we're going to try to look at that a little bit more. So it's also anti-edema, and it upregulates these antioxidants. So everybody knows how important these all are. I don't need to really spend much time talking about it. But the other thing that's very interesting is that nerve demyelination increases glutamate receptor expression. So you have somebody who has a problem. That problem then leads to more of a problem because it's upregulating the glutamate receptor, which is considered one of the big problems. And what blocks the glutamate receptor? Ketamine, right? So we use ketamine on every operative patient, and we treat a lot of patients with ketamine infusions that are not surgical patients because ketamine does a really great job. It's interesting that this drug's been around so long, but they're now finding more and more physiological mechanisms of action with ketamine. So ozone comes into play, and it helps this glutamate receptor not be quite so active. I already mentioned this, that medical ozone increases nitric oxide. Again, anything that we can do from a nitric oxide upregulation is always a good thing. It has many properties in addition to just addressing some of the hypoxic events. A couple of the other things that I found in the literature I thought was really interesting was that it increases or actually lowers blood viscosity. So the big drug 25 years ago was Trental, pentoxifylline, and its mechanism of action was, well, let's just make this RBC a little bit more slippery, a little bit more flexible, and maybe it can sneak through these smaller little capillary openings. And, you know, think about it, that's pretty cool. Ozone does the same thing that pentoxifylline does. So where we are now with chemotherapeutic-induced neuropathy is not even close to where we are from a diabetic peripheral neuropathy standpoint. But this might be where we need to look, and I think Dr. Schallenberger mentioned this in his talk on Thursday morning, and that is what's happening with the axon and the myelin damage, right? And ozone can induce tolerance to ischemic insults and attenuate ischemia reperfusion damage in various tissues. I won't go into this too much, but I want you to think about this from the standpoint of the best neuropathy to get is the one that you don't get, okay? And you know, what we're going to see in a couple more slides down the line, if they're going to have some chemotherapeutic regimen for their cancer, more likely than not, they're going to have a problem with peripheral neuropathy. And depending on the agents they use, you'll see in just a minute or two. But what's the other thing that we can do with ozone? And, you know, for some of these patients that have more of an isolated mononeuropathy. And there was a real interesting study here on carpal tunnel. And we've played around with subcutaneous and periarticular infiltration of ozone. And interestingly, it almost universally reduces their pain. In some patients, it lasts a lot longer. In other patients, it's maybe 5-10 minutes, and then they're saying, no, it hurts, more. But they did this study in treating carpal tunnel, and they found that it actually did well. They had a randomized group. The control group basically had wrist splinting, which is really, kind of one of the basic foundations of early conservative treatment for carpal tunnel syndrome. And they compared that with splinting and 1 ozone in infiltration. And they found that there were improvements in the electrodiagnostic testing in the ozone group. So it wasn't just somebody saying, well, I've got a better level of pain than I had before. You see all these studies that deal with VAS, and VAS is like ridiculous. I mean, one day they're a 25 out of 10, and then they saw their kids the day before and they hadn't seen them for a while, and now it's a 2 out of 10. It's a very variable thing. But electrodiagnostic is a pretty objective measure, and they saw that in the ozone group they did have an improvement in electrodiagnostic function. So what we have also is this reduction of oxidative stress. And so what's happening in chemotherapy-induced peripheral neuropathy? Obviously, a lot of oxidative stress. Now, we see the same thing very often, and that's why I said there's some chemotherapy-induced peripheral neuropathy that has a compressive nature. And for some reason, in a lot of the patients that were treated for breast cancer, it seems to hit the common fibular nerve. Well, that's the same nerve that Charcot-Marie tooth disease hits, and you have to start questioning it. Well, why is it? I'm sure that oxidative stress was pretty much the same throughout this person's entire body, but why is there this preferential nerve that seems to be more affected than others when it's the same level of oxidative stress that's going on? And the answer is that it's really hard to treat chemotherapy-induced peripheral neuropathy unless they have a very compelling clinical evaluation that shows that there is a nerve compression. And if they don't have a provocation sign or a Tunnel's sign and you decompress them, they're probably not going to get any better. But these folks are so desperate that
something went wrong. Please try again.
Okay. Well, there went my goal of having no audio-visual impairments this lecture. So, anyhow, but these folks are desperate. And if you talk to a lot of them, they'll say, yeah, if I didn't have this neuropathy after the chemo, I'd be doing great, but this neuropathy is just driving me crazy, or it's so painful. So this is where I think, I don't know how to accomplish this, but it would be really great that anybody who is going to undergo chemotherapy, that they started with ozone to really upregulate them, to mitigate these effects that happen on the peripheral nerve. And certainly it's a lot easier to prevent something, and it's kind of like a fire. If you have a little tiny match burning, it's pretty easy to keep that from getting out of control, but when the whole house is on fire, it's a pretty difficult thing. So I think this should be something that when you're talking to your patients, if you know that they're going to go undergo a regimen of chemo, it's like, say, hey, well, what about starting them on some supportive ozone treatments before, during, and after, and you're going to mitigate their symptoms. So, and this has been demonstrated in some studies, as we can see here. So, I don't know about this. I'm not an expert enough to tell you that this is the right dosage. This is just some of the stuff that's in the literature. And we found, of all of the ways that we have played with trying to administer ozone, I've found that rectal insufflation is probably the easiest from a practice standpoint, because if the patient has the means to get an ozone generator, they can quickly implement it at probably a much lower cost than coming in and having to pay per infusion. So it's I think for us, that's where we're trying to steer our patients. What about anxiety and depression? About 15% of my practice is suicidal. So when you have a nerve that is hurt, it works on the central nervous system incredibly. And they all have anxiety and depression. If you ask a patient that's had a nerve problem for a long period of time, do you have any anxiety or any depression? And they say no, they're probably lying. You know, they're being stoic, you know, but it's just almost impossible to not have these effects after you have a nerve injury that has been sustained for a long period of time. So we know that peripheral nerve cases cause anxiety and depression. I didn't realize how important this work really was until I had a patient come back to me, and this was early 2003, and he was a petroleum engineer. This is when I was practicing down in Houston, and he was mid-40s and a really successful guy, and his name was Roger. I don't know why you remember these certain things, but when something epical happens, then you kind of remember it. And so he came back at his first post-op visit, and he said, "You saved my life." And I was like, "Well, I think I made your nerves better, but I don't know that I saved your life." He said, "Oh, you don't understand." He said, "I had the gun loaded, I had it in my briefcase with the note to the family, and if I didn't see any improvement within the first week, there would have not been a second post-operative visit." So this is a compelling thing to get these people out of pain because they're suffering tremendously. So what are we trying to do when we treat peripheral neuropathy? Well, obviously pain is the number one, okay? But there's a subset of patients where the numbness is almost as bad as the pain. It just drives them absolutely crazy. And I've had some patients that say, you know, I have this thing, it's not painful, I can do my daily functions of life pretty well, but I'm gonna kill myself if I can't get rid of this weird thing because it's just driving me nuts. It's kind of like tinnitus, you know, it's just after a period of time, you just can't take it anymore. Loss of motor strength, we want to increase their motor strength so that we can help their balance. If we can, again, repair or get them to have some restoration of sensation, that's a really big thing, and maybe any other you know, weird symptoms that they have. So you have to treat both symptoms, but ideally you need to treat the cause. And I learned this very quickly, was very humbled by these patients that we had done nerve decompressions on, and we got them really much better, but we just didn't get them like ultimate. And so with ozone, we're actually able to maybe treat both the cause as well as the symptoms. So I think that's a really important thing. I already mentioned this. We've tried these different administration methods. We've kind of made rectal insufflation our default go-to now because it's just easier from an administration standpoint at the clinic. I've played with the local infiltration. I've actually seen more success with intra-articular injections of ozone than in the neuropathic situations. So, and you know, this is kind of where we go from the standpoint of administration. I mean, I don't need to talk to you all about dosage because you know all this much more than I know. So, in summary, neuropathy is super complex. Anybody that tells you that it's easy, run from them because they're the most disingenuous people that you could ever hang out with. And the more you go down the rabbit hole, the more you go down the rabbit hole because you want to try to help these patients. You want to try to figure out what else can I do for them and maybe intervene and make their life better. So the other thing, the take-home message too, is if you can find a component of compression, that's ideal because we can then decompress that nerve and give them a much better outcome. So that's all I have. Thank you for your attention this late on the Saturday afternoon.
This episode is sponsored by Zuckerman Future Technologies. Their REMI laser is a Class 4 laser for professionals. It's different from anything available on the market in that it is a lightweight, 4 pounds, and compact but powerful device. Its large touchscreen makes it easy to use, and The multiple wavelengths, 650, 810, and 980 nanometers, power variables up to 30 watts, and a safety rating make it optimal for many conditions, including the effective and pain-free treatment of soft tissue issues such as plantar fasciitis and Achilles tendinopathy, peripheral neuropathy, neuromas, arthritis, onychomycosis, warts, and more. It is the only laser with FDA 510K approval and insurance coverage. Zuckerman Future Technologies was built to focus on quality products and excellent customer support. When you join the REMI family, you will receive one-on-one training and ongoing support. Zuckerman Future Technologies deals with all aspects of the REMI in-house, and this keeps out the middleman, which allows them to offer this revolutionary device at a 40% reduced price compared to anything that can provide the same or similar results. In addition to this, Zuckerman Future Technologies provide a comprehensive, well-rounded marketing platform that includes customizable brochures and posters, in-office educational videos for your patients, as well as web page and hard copy ad templates. There are currently over 700 REMI users in the United States and Europe, and those numbers are rising every day. Learn more about this fantastic product and join the growing number of professionals who are benefiting from having the REMI in their practice. I personally implemented the REMI laser into our practice about 4 years ago, and I cannot say enough about the utility, versatility, and efficacy that I have seen with this technology. I also can say that of all of the capital equipment that I have purchased, and trust me, it's been a lot over the last 36 years, this is one of the best expenditures I have made. Zuckerman Future Technologies is offering the listeners of the Pot of Inquiry a really great deal. You'll get a $1,000 cart for the REMI laser when you use code 007. That's right, a $1,000 REMI laser cart for just the bona fide Pot of Inquiry spelunkers. You can go to the website, remilaser.com, and use the code 007.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, potofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pot of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pot of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.